Hi, this is the extra credit video project for Group 3, which includes Rithika Jamasetti, Annabelle Levin, Joe Kogan, and Jacob Fragan. The main question we were asked is, does technological advancement in healthcare help close inequality gaps, or does it systematically widen them? For the first round, our first question will be, do digital health tools such as telemedicine, digital apps, and wearable devices improve access for underserved communities, or do they exclude those without digital literacy? I will be speaking first. When we talk about healthcare technology and inequality, the starting point has to be access. Digital tools all assume that people have the basics: a reliable internet connection, a smartphone or computer, and the digital skills to navigate them. But if foundational access is unequal, then everything built on top of it simply reproduces inequality rather than solving it. And that's exactly what's happening today. Some may argue that digital health tools systematically exclude the same underserved groups who already face the greatest barriers to care: those without broadband, without devices, without digital literacy, and often without stable housing. These tools might seemingly benefit some people, but overwhelmingly, the people who may receive any benefit are already privileged. This is exactly the trend that sociological theories have been telling us already. Tuman's concept of the dysfunctions of stratification critiques the idea that the right people will automatically fill roles in society, which implies that the required and necessary resources will find a way to those who need or deserve them the most. But Tuman outright rejects this, explaining that this inequality isn't justified. It creates unfair outcomes, not on the basis of merit or deservingness, but based on unequal structural advantages that are so deeply ingrained in our society. These actively prevent people from fully participating in institutions that are essential for survival, like healthcare. When you introduce digital systems into an unequal society, they magnify inequality because the people who need them most are structurally unable to use them. Not only does the introduction of digital health tools widen healthcare inequality from a theoretical standpoint, but data backs this up as well. According to the most up-to-date FCC report, more than 26 million Americans still lack broadband access. These are mostly rural, low-income, and historically marginalized communities. Even when the internet is technically available, it's often unaffordable or unreliable. On top of that, older adults and low-income patients score significantly lower on digital literacy assessments, meaning that even if the technology exists, they can't navigate portals, apps, or insurance requirements. We can see this in real life. From the article, "A Smartphone is Not Enough," author James Lavadorf and other researchers concluded that during the pandemic, clinics serving low-income families reported that patients couldn't join telehealth appointments because their phones were prepaid, their data plans were limited, their Wi-Fi didn't work, or they didn't know how to use the patient portal. This often resulted in canceled appointments. For people with limited literacy, digital systems become one more obstacle between them and care. So while other speakers will argue that digital tools offer partial access, or that they expand access overall, or even that anyone with a smartphone can get care, all of those claims ignore a fundamental truth: the digital divide is structural. You can't overcome structural inequality by simply putting more apps into the world. And that means digital health tools, as they currently exist, don't close inequality gaps, they widen them.
Hello. My stance is that technology does help some people, but it kind of benefits the wealth in a disproportionate way. So I think Rithika is right that digital divides exist, but I disagree with her conclusion that technology helps no one. It does help people. The problem is who it helps and at what scale. Digital healthcare tools, such as telemedicine, health apps, wearable trackers, these absolutely expand access, but they distribute the benefits unevenly. And that unevenness is exactly what fuels deeper inequality in the long run. To understand this, we can turn to Michael Sandel's argument in What Money Can't Buy. This is a big piece of information in our class, and Sandel kind of explains that when market logic takes over social institutions, especially something as essential as healthcare or anything like that, the inequalities of money become inequalities of access, dignity, and life chances. The markets don't just allocate goods, they kind of reshape the meaning of those goods, if that makes sense. They turn to public needs into these kind of commodities, and they apply healthcare tech, which means that the digital tools meant to expand access actually become market products, and those kind of benefit the people who can pay for them because these are high quality devices, subscriptions, insurance, insurance integrated monitoring systems. And as an example, we can see that telehealth visits surged kind of during the pandemic, but not evenly. I got this from the US CDC, and apparently they asked non-emergency medical providers to prioritize telehealth consultants. So people living in cities jumped at this opportunity, opting to receive their care via phone, computer, or a digital app. As a result, telehealth utilization kind of climbed across the board. This kind of finding was supported by another finding. This was a study by the American Journal of Preventive Medicine. This was in September of 2021, which is a little bit of a while ago, but it was right post-pandemic, and it found that telehealth usage was slightly higher in the metropolitan areas than it was in rural areas, and additionally, people living in low-income communities had a lower uptick in telehealth visits. Apart from telehealth, this trend applies to other healthcare technologies, kind of like remote patient monitoring programs. There's also like powerful tools that prevent these complications, but these programs are overwhelmingly available through private insurance plans, however, not Medicaid. And this is kind of where I depart from Rithika's point, because she's right that technology excludes many, but is wrong that it excludes everyone equally. So my conclusion is this: digital healthcare technology doesn't just reflect inequality, it monetizes it. And as Sandel warns, once market logic becomes a part of a system, those with money buy not only better services, but better outcomes and better futures. Technology helps, but it helps the wealthy first, fastest, and the most fully.
Rithika argues that digital tools overwhelmingly exclude underserved communities, and Jacob says that they help but mostly reinforce inequality. But both miss the bigger point. When underserved groups have access to tools, support, and infrastructure, they use healthcare technology effectively and benefit tremendously. Technology isn't perfect, but its net effect is a major expansion of access. Modern sociology rejects early culture of poverty stereotypes, which claim that poor communities couldn't use resources effectively. Instead, marginalized groups appeared disengaged only when access is unstable. Once supportive structures exist, participation and outcomes improve as much as any other group. In short, people aren't hard to reach, they're easy to ignore, and inclusion drives results. Telehealth during the pandemic shows this clearly. Rural telemedicine visits expanded dramatically. Research published in PubMed and the Journal of Medical Internet Research found that the safety net clinics serving rural communities saw large increases in telehealth use once barriers like travel distance and specialist shortages were lowered. Patients who had faced obstacles before engaged immediately when access became feasible. Mental health care shows the same pattern. A study in PubMed reported that switching to remote video or phone visits cut no-show rates by about 50% among low-income patients. This wasn't because patients became more digital, it was because teletherapy removed barriers like transportation, unpredictable work schedules, and childcare. Mobile clinics offer another concrete example. In rural Texas, mobile screening mammogram units paired with telehealth reached uninsured women. A report from the Neiman HBI showed that participation and early detection rates rose dramatically. Those weren't tech-savvy elites. They were working-class women previously excluded from preventative care. Once infrastructure was in place, engagement happened immediately. So, while Rithika is right that digital divides exist, and Jacob is right that wealthier groups gain first, they miss the larger picture. Technology expands what's possible for underserved communities, removing barriers like broadband coverage, device availability, and high data costs allows rapid adoption. The issue isn't ability, it's access. In summary, technology increases access for most people, reduces travel burdens, improves chronic condition management, cuts wait times, and brings specialists into communities long neglected. Yes, the wealthy benefit too, but underserved populations see massive gains when tools are accessible. Technology doesn't fail people. Lack of access does. When access is ensured, these communities thrive.
Hey everyone, so when listening to Rithika, Jacob, and Annabelle, I do understand where they are coming from. They're each pointing out real barriers, whether it's digital literacy, cost, or even the need for support. But I do think the three of them are missing something very critical that's actually pretty encouraging. We're living in a moment where access to healthcare for both the rich or the poor isn't just tied to geography anymore. A century ago, if you were living in a rural town, per se, a reservation, or even just a neighborhood that didn't have a lot of clinics or didn't have a lot of access to medical care, you were basically stuck. Today, a smartphone, just like this, can connect someone to a doctor, a therapist, lab results, health education, 24/7 medical coverage just with the phone itself. And not to say that's all that's needed for someone to be able to live a successful life, but it is something way more beneficial than 100 years ago. And the crazy thing is that according to the Pew Research Center, 85% of low-income Americans own smartphones. So that means the device that connects them to care is already in their pocket, 85% of all people. So when Rithka says that unequal foundations make digital access unequal, while that is partially true, it also ignores how fast these foundations are changing and evolving as we are in 2025. When Jacob warns that wealthy people benefit more from new tech, that's also true at first, but historically, the early adopters always pay the high cost. And in a sense, what I mean is that tools become cheaper for everyone else when this happens. Even Annabelle, who makes a good point that says the impact is net positive, she kind of undersells how transformational this actually is, that this access is available to all people. We're already seeing this telehealth in community clinics, even remote ultrasounds in mobile vans, and teledermatology reaching places that never had dermatologists before. A pregnant woman who used to drive 2 hours for a scan can now get one 5 minutes from home. To me, the question isn't, does technology exclude people? The question more so is, how quickly can we expand and scale something that has the potential to reach millions that were ignored or omitted before? This is not a small improvement. It's the biggest expansion, in my opinion, of access in modern healthcare, and I think that matters way more than the limitations that my other three peers made prior.
The second question is, does AI automation pose risks to the medical sector, and how far can it really go? AI, which relies on data, algorithmic control, and corporate platform power, compounds economic inequality at a much deeper level. To understand how, we can turn to Yanis Varoufakis' theory of techno-feudalism, which describes a world where we don't interact in a free market anymore, but instead inside digital fiefdoms ruled by a few platform lords. Varoufakis explains that when you enter Amazon, you basically exit capitalism. The same thing is happening in healthcare. When hospitals adopt AI systems created by a tiny handful of private companies such as Epic, Cerner, Google Health, United Health, and others, they aren't participating in a competitive market. They are entering digital fiefs where the algorithm itself dictates what doctors see, what patients are recommended, and who gets prioritized. In a techno-feudal system, the algorithm functions like an algorithm sheriff, policing decisions, granting access, and collecting data, all while remaining invisible and unaccountable. This framework reveals why AI is so dangerous for marginalized patients. AI doesn't just make mistakes, it automates the unequal distribution of care. One of the clearest examples comes from a study published in Scientific American in 2019, which explained that a hospital AI used for patient risk scores underestimated the illness severity of Black patients by 40%. That meant they received less follow-up, fewer specialist referrals, and delayed treatment, not because of one doctor's bias, but because the algorithm embedded the bias into the entire system. In Varoufakis' terms, AI turns marginalized patients into digital serfs, living in the healthcare fiefdoms of algorithmic lords. Their data is extracted, sorted, and evaluated through models built by privileged groups, trained on biased datasets, and governed by corporate incentives rather than patient needs. The more AI becomes centralized, the more a handful of companies act like digital kings, deciding who gets access, who gets flagged, and who gets ignored. We are already seeing techno-feudal dynamics in hospitals. A study published in the journal called Science in 2019 also showed that facial recognition systems misidentify Black patients at far higher rates, which leads to administrative mismatches that can affect medication orders, patient tracking, and triage decisions. And large health platforms increasingly own the data pipes that providers rely on, giving them the power to determine what information information doctors see in the first place. So when we talk about AI risk, we can't frame this as neutral automation. In a techno-feudal system, automation always serves the interests of the digital lords first. AI is not democratizing healthcare, it is centralizing it. It reinforces platform dependence, extracts value through data, and deepens the divide between privileged and marginalized patients. When healthcare becomes a digital fief, inequality isn't just preserved, it's operationalized. And marginalized patients, just like digital serfs, have the least power to resist or escape an algorithmic system that was never built for them in the first place.
So now to speak more on the AI portion of this, which is what kind of applies more to our world today. We're going to talk about how AI's risks kind of hit undeserved groups the hardest, so the people that don't have access to it in a sense. I align with Rithika's point, but not like strongly, I would say in a light way. But there is definitely inequality and structural conflict that need to be emphasized here. So I agree that technology is transforming healthcare, but I argue that the benefits of that transformation are distributed unequally. While tech absolutely has the power to improve efficiency and expand access, the question is, improve it for who? So who would you improve it for in a sense? Because there's so many different groups. There's a vast amount of wealth spread across these groups. And through a conflict theory lens, we can see that technological benefits tend to flow toward groups and institutions with the most resources, while the downsides, errors in personality, algorithm failures kind of fall disproportionately on marginalized communities. But consider who can actually take advantage of the tech-driven healthcare. So wealthier patients often have private insurance, stable internet, access to hospitals with kind of highly functioning digital systems. They get telehealth appointments that run smoothly. They get AI-backed diagnostics that are kind of interpreted by specialists and wearable health monitoring that doctors actually review. Now moving into the lower income patients, you can kind of see here that they don't get the same experience. They get glitchy telehealth, kind of an overloaded hospital portal, and there's kind of errors that there's not like one set error, but there's a different error every time, if that makes sense. Kind of errors in the automated reminders, and there's definitely long waits that are caused by understaffed systems hiding behind efficiency software. So while Rithika focuses on the risks of technology and Annabelle focuses on the benefits, my argument is that both are true, but unequally. The people with high quality healthcare will continue to see technology amplify that quality. Those with low quality healthcare will see technology amplify that as well. If the healthcare system already has structural inequality, and this unequal access and unequal time and unequal quality, then layering technology on top doesn't fix the problem. Paul Braverman in 2014, he kind of cited this source about how public health is disproportionately, I wouldn't say shared, but disproportionately equal in a sense. So his article was labeled "What are health disparities and health equity?" And he talked about how health kind of magnifies the inequality that was already there. So the question isn't whether tech helps or harms healthcare, it's how tech interacts with inequality that already exists and who gains or loses in that process. And yeah.
Both Rithika and Jacob raise important concerns. Rithika focuses on worst-case biases in algorithms, and Jacob points out that wealthy systems often benefit first. But both miss a crucial point. When AI tools are properly regulated, tested, and monitored, they can dramatically improve healthcare outcomes for most patients. The question isn't whether AI is dangerous, it's whether we build the guardrails around it. Structural functionalism helps explain this. Our healthcare system is overwhelmed. Clinicians are overworked, shortages are rising, and diagnostic errors are a leading cause of preventable harm. AI isn't here to replace doctors. Rather, it fills critical gaps in an overburdened system. It strengthens the structure so the whole system functions more effectively. The evidence is compelling. For instance, a 2025 study in breast cancer research found that AI screening tools detected breast cancer with about 99% accuracy, outperforming standard radiologist readings and catching tumors earlier, even across varying breast densities. Similarly, deep learning AI algorithms in multiple datasets show nearly 99% detection accuracy, demonstrating robustness across populations. In critical care, AI tools save lives too. A 2024 study using AI for sepsis prediction found that the algorithm reduced mortality by 20 to 30% by flagging deterioration hours sooner than human clinicians could. These systems don't replace doctors, they provide faster, more accurate information so patients get the right care sooner. Real-world hospitals, even with limited resources, show the same pattern. Rural hospitals using AI-powered triage tools cut emergency transfer times, improving outcomes for strokes, heart failure, and trauma. These aren't wealthy hospitals buying fancy toys. These are under-resourced facilities using AI to provide a level of care they couldn't previously offer. Addressing earlier concerns, Rithika is right that bias exists, but it is solvable with regulation, auditing, and representative training data. Jacob is right that resources aren't evenly distributed, but AI raises baseline performance across the system. Inequality matters, but it doesn't erase the fact that AI delivers major benefits when deployed responsibly. So, my argument is simple. AI, when well regulated, improves care for the overwhelming majority of patients. It reduces diagnostic errors, supports overworked clinicians, speeds triage, and makes high-quality care more reliable. The solution isn't fear, it's oversight. With the right guardrails, AI strengthens healthcare and helps it function the way it should.
When the conversation shifts to AI, I do think that everyone suddenly gets very worried, and I do understand why. But I don't think we should talk about AI as if it's this fixed, unchanging thing that's either good or bad depending on the circumstance. AI models do get updated constantly. They improve as early flaws get exposed, just like any other sort of technology. Take stroke detection, for example, which is something that I researched during this project. The Mayo Clinic, which is one of our sources, found that certain AI-enabled imaging systems that have been developed the past 5 years cut the time from scan to diagnosis by almost 50%, 50. That's not just a small upgrade that we could just scoff at and say, oh, that's pretty nice. That's the difference between someone walking again and having a life with a family or living with permanent disability. That is the kind of improvement that doesn't just benefit wealthy people, as some people in my group would argue. It eventually will be able to help everyone as it becomes standard equipment, which I believe will happen eventually. So when Rithika says AI industrializes bias, I do understand the concern, but that assumes that the system never corrects itself. While AI can be faulty nowadays, it is a relatively new product. Take the iPhone, which was discovered in the 2000s. The first model came out in the 2000s. The iPhone in 2008 is not the same thing as it is now. We would laugh at what we saw in 2008. Technology develops. So when Jacob also argues that elite hospitals get safer AI while poor hospitals get outdated versions, again, this could be true right now as that's just how capitalism works. But technology as it develops, poorer hospitals will begin to get better technology. Innovation starts at the top and I believe will spread downwards as costs fall, economies of scale. That doesn't mean we shouldn't regulate it, it just means the process is predictable. And when Annabelle mentions regulation, I do agree completely, but I'd also like to add that innovation itself acts like a form of regulation because every generation of model uses bigger and more diverse data sets and technology on the internal side. Look at teleophthalmology. Sorry, that's hard to say, but in other words, that's AI dermatology tools or virtual symptom checkers. Are they perfect? No. Are they new? Yes. But for someone with, say, no insurance, little transportation, or a packed work schedule, someone who's below the poverty line, maybe, these tools are sometimes the only doorway into the healthcare system. Listen, the more we improve and refine these tools, in my opinion, the more they help the people who are shut out the longest. So yes, I will admit that AI does have its risks, but the benefits grow faster than the risks do, in my opinion, and we shouldn't pretend otherwise. AI is a tool, and while it can be dangerous, it can revolutionize the medical sector and can help people that could have never thought getting certain type of help being something that they can get every single day and not think about twice. AI is our friend, not our enemy, especially if we use it correctly.
The third round question is Is the cost of healthcare rising, and does technology exacerbate or alleviate that? In the last round, we talked about how AI systems reproduce inequality through biased data and corporate control. But the harm doesn't end with discrimination. There's another side of this story that we absolutely have to confront. Technology is driving the cost of healthcare up across the entire system. It is a structural feature of the economic era we live in. To understand why, we can turn to the social structures of accumulation theory, otherwise known as SSA. It explains that capitalism moves in long cycles where institutions, technology, and state policies align to create an environment that allows the capitalist class, today's billionaire class, to accumulate enormous wealth. Meanwhile, the working class remains stagnant or falls behind. In our current phase of neoliberal tech-driven capitalism, innovation is not designed to reduce inequality. It is designed to extract profit, especially through privatization and monopolistic control over critical infrastructures such as healthcare. This is exactly what we see with medical technology. AI systems, diagnostic algorithms, digital health platforms, and proprietary devices all have very high expenses. Hospitals spend millions of dollars each year maintaining digital infrastructure. These costs don't disappear. They get passed on to patients in the form of higher bills, premiums, deductibles, and device costs. The data is undeniable. According to Definitive Healthcare, the average cost of surgical and medical equipment cost hospitals $43 million per year, an increase of 6.5% in just the last few years. Now, while that percent increase might sound small, it directly causes the price of medical bills and hospital visits to increase. This isn't a coincidence. It is the precise pattern SSA predicts. New technologies generate new profit streams for corporations, and the capitalist class uses these technologies to expand wealth, while the working class absorbs the financial burden. Let me give you a real example. Like the continuous glucose monitors that were mentioned earlier, which should be life-saving tools for diabetics, it was not mentioned that these tools now often require monthly subscription fees. If you're uninsured or underinsured, these costs become completely unaffordable. Even insured patients face high co-pays because insurers classify the devices as premium or optional. Meanwhile, the companies creating these devices report record profits and rising shareholder value. This is SSA in action. Technological innovation becomes a new method for accumulation at the top, while working class patients are priced out of basic care. This is why inequality expands even when technology improves. The wealthy gain access to better care, while the working class face rising costs and fewer pathways to consistent care. In an SSA framework, this is completely predictable. Capitalism in its current phase relies on high-cost innovation to generate profit, not on affordability or universal access. Annabelle and Joe will say technology lowers costs in the long run, but long-run projections don't change the fact that right now, costs are rising sharply, and working-class patients are the ones absorbing them.
So my round 3 segment is to kind of talk about how technology kind of lowers some costs, but kind of increases inequality, the inequality of affordability. And the purpose of my segment here is to kind of emphasize the unequal financial burdens, but also how conflict is framed. So technology is often marketed as a way to lower costs, but the reality is a lot more complicated. Yes, technology can reduce costs at the system level, but those savings do not necessarily reach patients. And in fact, technology often leads to new types of financial inequality that people don't really see often. So I want to give an example here. Some hospitals kind of invest millions into advanced AI diagnostic systems to improve efficiency. Wealthy, well-funded medical centers absorb that cost and then pass minimal increases to the patients. But these underfunded hospitals, kind of, especially those that are in rural or low-income areas, they also adopt technology, but without the subsidies or strong infrastructure to uphold them. These upgrades kind of produce higher bills. There's a greater administrative fee, and these new charges under the label of digital services, the same tool that saves money for the one hospital raises prices for another. So to make that more clear, there's new charges under the label of digital services, and the same tool that saves money for one hospital area kind of raises prices for another, to break it down in simpler terms. So now moving on to insurance coverage. This also plays a huge role. Julia Adler-Milstein, someone who studies medicine and has a PhD from it. She wrote an article in 2017 about the financial effects of electronic health record optimization. So with regards to private insurance, these plans often cover telehealth, digital monitoring, and AI-supported care, which is what Julia Milstein kind of covered in her writing. The Medicaid coverage is inconsistent, varying by state, meaning that low-income patients can be charged full price for digital services that wealthier patients access inexpensively. There's another example of how technology benefits through privilege. So some people get it, some people don't. But the bottom line is that technological cost savings just aren't equally distributed in a sense. So these wealthier institutions and wealthier patients and these kind of well-funded insurance plans get cheaper and more efficient care, which is kind of what my whole talk is about. So everyone else gets either cost increases or a restricted access. But this technological disparity and income disparity spread across social classes is the main effect here.
Both Rithika and Jacob focus on the upfront costs of adopting new technologies, the price of devices, implementation, and the risk that wealthy systems benefit first. Those are valid concerns, but they miss the larger picture. Technology dramatically lowers healthcare costs over time by reducing preventable hospitalizations, improving chronic disease management, and cutting down on expensive medical errors. In fact, well-designed remote patient monitoring and telehealth programs can save far more than they cost to implement. Using a stratification theory lens helps make sense of this. Yes, inequality persists and wealthier systems often adopt new tech fastest, but as the system becomes more efficient overall, savings and improved care can ripple outward, making healthcare more affordable and accessible to a broader audience. Efficiency gains don't just help top-tier hospitals. They benefit underserved populations too. Inequality doesn't disappear, but the financial burden of care becomes lighter across the board. For example, a 2025 review of remote patient monitoring for chronic diseases found that RPM possibly reduced hospitalizations compared to usual care, which, even modest reductions, translates to significant cost savings because hospital stays are so expensive. Another study of high-risk post-discharge patients found that home monitoring reduced emergency department visits and hospital readmissions substantially over a 3 to 6 month follow-up period. In more dramatic cases, PubMed describes a program for patients with conditions like chronic obstructive pulmonary disease or heart failure showed ER visits dropped as much as 68% and hospitalizations dropped 35% after remote monitoring implementation over just 3 months. That study concluded, although RPM requires an upfront investment, it has the potential to reduce healthcare costs to the system over time. We also see real-world savings in home monitoring programs. According to Medical Economics, a recent initiative at a major U.S. health system saw nearly 60% fewer hospitalizations among high-risk patients using remote monitoring. That kind of reduction drastically lowers the burden on hospitals, reduces costs, and prevents expensive overnight stays and readmissions. So, returning to earlier arguments, Rithika is right that technology can raise costs at first, but those early expenses fall sharply as preventable emergencies decrease. And Jacob is right that wealthier systems may adopt tools first, but the cost savings generated by reduced hospitalizations, better chronic care management, and fewer ER visits ultimately benefit more than just the wealthy. Lower costs expand access. That is why my argument is simple. Technology, when implemented thoughtfully and fairly, is one of the most powerful drivers of long-term cost reduction in healthcare. It prevents crisis, improves chronic disease management, reduces unnecessary hospital stays, and lowers overall spending. The initial investment is real, but the long-term savings are far greater, and those savings benefit the entire system, including underserved communities.
So I do think cost, which is an important part of this whole argument and really where it all boils down at the end of the day, because money is what drives our economy, drives our society. I think this is where this debate gets a little emotional. So, for example, Rithika argues that tech drives costs up because equipment and training are expensive. And Jacob also says wealthy people get the financial benefits first. Annabelle says tech saves money in the long run. long run. I actually think in your own ways, all three of you guys are right, but you're each focusing on just one part of the timeline. If you look at any major medical innovation, the pattern is always the same. Expensive at first, cheap later, and then even life-changing for everyone. And I know I said this earlier, but in economics, that's called economies of scale. As technology increases, as your costs increase in the short run, if done correctly, if a successful enterprise, then later costs will decrease. The best example that I can find, hence the picture, is genome sequencing for DNA. The National Human Genome Research Institute reports that sequencing the first human genome cost $100 million at first. Today, that's around $600. And to do the math, that's a 99% price drop. And once insurance systems start covering something, it stops even being a luxury. Telehealth also reduces costs through volume. For example, a doctor who used to see 15 patients in person might see 25 virtually now. And this is a perfect example because technology allows virtual visits to be possible. We take virtual visits, Zoom meetings, FaceTimes for granted nowadays. 30 years ago, that wasn't even possible. Virtual meetings weren't a thing. Virtual work days were barely even a thing, let alone meetings over the phone, seeing people's face. Remote monitoring prevents expensive hospital readmissions, for example. So yes, in my opinion, in the short term, technology does look expensive. It is expensive. As technology evolves, it is expensive. The new hot product on the market will always be expensive. I'm not arguing that. What I'm arguing to my other three peer mates, or not arguing, just kind of articulating, is that if we zoom out, the real question is kind of the opposite. How much does it cost us not to innovate? What I mean by that is without tech, we keep paying for preventable emergencies, late-stage conditions, and inefficient systems. With tech, we shift toward early detection and smarter resource use. The better technology we get, the faster we'll be able to analyze and observe things. You always hear doctors saying, 10 years ago, we would have never been able to catch it. For example, a cancer diagnosis. But now you start to see early diagnosis, early analysis. So to me, the long-term math is obvious. Innovation will, and I hope is going to, pay for itself many times over. So that is why we need to keep innovating and not let the short-term present costs get in our own heads, as we have to understand that the more innovation and the more technology, the more AI, the more genome sequencing, the better it will be in the long run.
The round 4 question is, does reliance on tech reduce patient-provider interaction, harming care for vulnerable groups? In the last round, we saw that technology raises costs and deepens financial inequality, but there's another effect we need to address. Technology reduces the quality of care for the people who rely the most on human interaction and culturally competent support. This follows the exact pattern Robert Reich describes in When Robots Take Over. Reich argues that automation in our current economic system isn't used to empower workers or improve service. It's used to replace human labor, cut costs, and maximize corporate profit, even when this worsens the experience for the people being served. Automation doesn't just remove jobs. It hollows out human relationships and turns essential services into low-touch, robotic transactions, and healthcare is now moving in that direction. When hospitals adopt automated check-ins, chatbot symptom checkers, and digital-only follow-up systems, they are not prioritizing patient experience. They are prioritizing efficiency and labor savings. Reach warns that when technology becomes a substitute for human care, the workers who remain are overloaded, undervalued, and given less time with patients. Meanwhile, vulnerable groups such as older adults, immigrants, low literacy patients, and people with chronic conditions receive care that is more rushed, more impersonal, and more prone to error. That is exactly what we're already seeing. According to the article in August of 2025, Hadil Zaghloul and others show that patients with low digital literacy have significantly higher rates of miscommunication and worse chronic condition outcomes in digital-first systems. They explain that while digital health is a promising solution, it is not effective without digital health literacy, especially in the treatment and management of chronic conditions. Those with lower digital literacy are not bad with technology. The system is just built around automated interactions that they were never prepared for in the first place. The consequences can be disastrous. For example, when elderly patients struggle with online portals, they miss medication refills, lose follow-up reminders, and often suffers silent clinical deterioration because no human being is checking in on them. Reacher's theory explains why this happens. Automation expands fastest in sectors where the people being served have the least market power. Vulnerable patients cannot shop around for better care or opt out of automated systems. They become the testing ground for cost-cutting technologies. Meanwhile, wealthier patients still receive concierge-level human care. This is not equal access. This is institutional discrimination, amplified by automation. The very patients who rely on human connection the most are the ones pushed to automated services. The technology does not simply reduce human interaction, it reduces disproportionately for the people who need human interaction the most. And this is where I disagree with Jacob, who will argue that the wealthy simply get a better version of tech. That's true, but it misses the deeper point. Automation worsens the care at the bottom by design. It's not just uneven quality, it's declining quality for the most vulnerable. And I disagree with Annabelle and Joe when they say that tech enhances care. It enhances care for whom? The people paying for premium digital platforms and private clinics only. For everyone else, automation means fewer humans and more exclusion.
So moving to the fourth round, in this segment, I wanted to emphasize how high quality care remains exclusive to the privileged, kind of what we've been talking about all the way up to this point, nothing new. My purpose here is to kind of emphasize that tech does improve outcomes unevenly and it reinforces inequality gaps. So when it comes to the quality of care, the story is similar. Technology genuinely improves outcomes, but not for everyone in the same way. And the AI diagnostics do reduce errors that we do see, and the digital alerts catch early warning signs, and the telemonitoring helps prevent hospitalizations. These benefits cluster around institutions with the resources to use them correctly. In hospitals, without strong IT support or adequate staffing, the same technology can actually worsen care. So for instance, AI-based systems can flag deteriorating patients earlier than human review alone, but only when the teams have the training and time to respond. In overburdened hospitals, especially safety net hospitals, the alerts pile up and the staff become desensitized and the quality gains disappear. And this isn't a problem with technology itself, it's a problem with the unequal healthcare environments. So even something as simple as electronic health records show this divide. I studied a professor named Tricia Greenhall. She wrote about this thing in she actually wasn't a professor, she was just a researcher. She wrote about this thing in 2018 called Digital Health, a Realist Review. And she kind of stated that even something as simple as electronic health records show this divide. High quality systems reduce medication errors and streamline communication. Poorly implemented systems create new opportunities for mistakes, from wrong entries to duplicate orders, which disproportionately harm patients and underfunded facilities. Again, the same tool kind of produces different outcomes, and I'm sure my peers have already talked about this, even if they're on a different side. But even if a tool produces a different outcome, it kind of depends on what care you receive and what hospital you go to and what kind of health care you get. And telehealth quality varies. Wealthier patients get longer appointments, integrated video platforms, and follow-up messages from their provider's team. And then on the other end, there's lower income patients who experience short rush calls or glitchy video where the provider barely has time to connect before the call drops. Outcomes kind of diverge, not because the patients are different, but because their access to functioning technology is just different in a sense. And technology doesn't inherently raise or lower quality. It raises quality in context with resources, and it lowers in context without them. And that's this pattern that keeps on repeating.
We have been missing something essential. When integrated thoughtfully, technology measurably enhances the quality of care for the vast majority of patients. It improves communication, reduces clinician workload, and strengthens clinical decision-making across the board. Think of this through a lens similar to credential inflation adapted to healthcare. As society raises standards over time, healthcare technology raises the baseline standard of care. Tasks that once relied on memory or paper, like medication reminders, appointment follow-ups, symptom logging, or documentation, can now be automated or streamlined digitally. Technology doesn't replace providers, it raises what we expect from everyday care, lifting the entire system upward. And data backs up these claims. Take patient portals and remote care tools. Research from the Journal of Medical Internet Research shows a 2025 mixed method study of a low-income, historically underserved urban community found that about 72% of participants had used a patient portal at least once, and many reported that using the portal made them feel more actively involved with their health. Another recent review in the JMIR found that telehealth interventions in pharmacy and primary care settings, including remote monitoring and telemedication management, often improved access to care and operational efficiency, especially in underserved or rural areas. In mental health care, technology makes a real difference. A 2022 national survey from PubMed showed that among adolescents receiving mental health treatment, nearly 45% use telehealth for some portion of their care. For rural or underserved patients with serious mental illness, greater use of telemental health was associated with more specialty mental health contacts and better follow-up after hospitalization. These gains matter deeply in places where in-person care is harder to access. By automating routine tasks such as reminders, check-ins, documentation, technology frees up clinicians. That means that there's more time for face-to-face or video-to-face care when it matters. It reduces provider burnout and allows more consistent, higher quality care. For patients, it means easier access, fewer missed appointments, and better long-term management of chronic conditions. So yes, while no technology is perfect and structural inequalities remain teal, tech supplements human care. It doesn't just replace it. And often, it makes care measurably better. That's true not just for well-resourced clinics, but for rural and low-income communities that have historically been underserved. Against Rithika's point of view, technology doesn't have to be a threat. With oversight and thoughtful implementation, it becomes a tool to enhance care. Against Jacob's point of view, yes, resources may skew access at first, but once implemented, technology raises the system-wide quality of care, benefiting broad populations, not just the privileged. And even for those who argue human connection is irreplaceable, tech doesn't remove the human element. Instead, it reduces friction and gives providers space to focus on meaningful human interactions rather than paperwork and logistics. That's why my argument is simple. Technology enhances overall care. It streamlines communication, reduces burnout, expands access, and raises the standard for what good care should look like. When used responsibly, tech doesn't pull healthcare away from humanity. It brings healthcare closer to it.
So this is also an interesting point because I think this idea of, personal interaction is kind of the emotional side of healthcare, the human connection that people are scared of losing. Rithika worries that tech will replace human care, a doctor talking to a kid face to face. And Jacob warns that the wealthy will get hybrid care, so a little bit of both, while low-income patients will get stuff like automated messages. And lastly, Annabelle argues that tech, frees up providers to spend more time with complex cases. Well, these are all fair points, and I can't say that none of these aren't true. Here's where I think the conversation shifts and should shift. Technology adds more interaction, not less, just in a different form. At the end of the day, we don't want to interact with healthcare, right? At the end of the day, you want to limit the amount of healthcare interactions you have. While when we are interacting with healthcare, we want it to be face-to-face with a human ideally. But what I think technology does is in the long run, it's actually going to decrease the amount of times we have to be at a facility with healthcare altogether. Let me explain what I mean by that. Remote monitoring is a great example that's been prevalent in the last 20 years with the shift of technology. A JAMA study, JAMA study, found that remote monitoring programs cut readmission rates for conditions like heart failure by almost half. Now you ask why? Because instead of waiting for a patient to get dangerously sick as they have to go through the bureaucratic system where you can't get an appointment or you're waiting in line, providers will be able to just get alerts the moment something looks off, as it's all digital, which leads to early check-ins, quick messages, medication adjustments, even phone calls through the web. Continuous care. So while they're not actually going to the doctor's office, they are just getting human care just in a more extensive way. Additionally, with diabetic patients, as some of my friends have diabetes themselves, they use continuous glucose monitors, as one of my friends has a continuous ticking device on his arm at all times. Is the relationship between patient and provider. Once again, they're not actually seeing each other, but it's constant, not occasional, which is what it is now. Annabelle is right. Technology can reduce burnout by giving doctors real support, not endless paperwork. And additionally, when Jacob worries that the wealthy get a real doctor while others get bots, in a sense, I do understand that fear, but many of the communities benefiting most from remote tools right now, when you think about it, are low-income patients who can't take time off work to go to the doctor, who don't have transportation or the money to get a train to go to the doctor's office, or who've never had regular follow-ups. For me, I live in a town in New Jersey where I have a doctor's office 2 minutes away, but there's some people that live in rural Missouri that don't have a doctor's office within 10 miles of them. So this type of technology innovation is imperative for them. Technology doesn't eliminate human care. It kind of turns, in my opinion, occasional contact as a daily checkup into ongoing support. For vulnerable groups, such as the poor or people in sparsely doctored areas, this can change everything.
The question for the last round is, given all of the evidence, what impact does healthcare technology have on health outcome inequalities? Across the entire discussion, all four of us have pointed to real patterns in how technology is reshaping healthcare. But when you trace the structure behind those patterns, the conclusion becomes clear. Technology is deepening health inequality because the institutions deploying it, markets driving it, and the outcomes it produces are all unequal. So let's dive into why this conclusion is the only one that fits all of the evidence, and why the other speakers, despite raising important points, ultimately reinforce this claim. Jacob argues that technology helps everyone just unevenly, and he's right that the wealthy adopt and benefit first, but he treats that as a side effect rather than the central mechanism. When access, literacy, broadband, insurance, and digital coaching are all unequally distributed, any technology that relies on those preconditions will scale inequality. Even if telehealth or wearables provide some benefit to underserved groups, privileged groups see faster detection, better adherence, more coaching, fewer ER visits, and better data. That means the gap widens even while averages rise. Jacob is describing the phenomenon well, but the part he minimizes is the part that matters. When the privileged always move forward faster, inequality accelerates. That is the pattern we see across every data set and institution. Annabelle stresses that when technology is supported with proper infrastructure, underserved communities benefit. And she's right, but those conditions themselves are rare and unequally distributed. Her examples mostly highlight pilot programs or safety net clinics with unusual levels of support. She interprets them as proof that technology works, but they actually prove my point. Technology only narrows inequality when we temporarily remove the very structural barriers that define the system. Once the grant ends or the funding shrinks, those gains disappear. Access is fragile for the community she describes because the surrounding structure is unstable. So yes, when you artificially smooth out inequality, the tech performs well. But that doesn't describe the system people live in every day. And Joe argues that innovation always spreads, becomes cheaper, and eventually brings everyone up. But that model only works when technologies operate in competitive markets with broad distribution. Varoufakis shows that modern healthcare does not function like that. It functions like a techno-feudal system, where a handful of companies control the platforms, the data, the algorithms, the billing codes, and the infrastructure hospitals must use. Innovation doesn't diffuse, it gets captured. AI tools get better where hospitals can afford data scientists and auditing teams. Even if costs fall over time, the quality, speed, and safety of those innovations remain stratified. So while the other speakers are right to some extent, none of the conditions they describe reflect the system we currently have. In the system, technology does not level the playing field, it tilts it further. Therefore, healthcare technology as it currently exists systematically deepens health outcome inequalities because the structure itself is designed to reproduce inequality.
So now to get into the final round, and this is kind of where I kind of talk about what my peers said in this podcast and what I kind of believe based off of that. Before I close, I kind of want to respond directly to the arguments made to Rithika and Annabelle specifically, because the heart of this debate isn't whether technology is good or bad, but it's who actually benefits from it. First, to Rithika, you brought up the idea that technology strips away empathy, face-to-face communication, and the emotional labor that makes healthcare humane. I don't disagree with you. That absolutely does happen, but the key point you're missing is where it happens and who it happens to. So wealthier patients at well-funded hospitals still get long appointments, direct communication, and providers who aren't drowning in automated systems. It's low income and Medicaid and uninsured patients who get routed through chatbots, automated portals, and rushed digital interactions. So yes, empathy is lost, but it's lost unequally, in my opinion, and technology doesn't inherently reduce compassion. Unequal institutions do. The loss of human connection is a symptom of structural inequality, not the tech itself. Now for you, Annabelle. You argue that technology improves outcomes, better diagnostics, quicker results, fewer medical errors, and I agree with most of what you said. But again, the problem is that those benefits are not equally distributed. They're not evenly distributed. The AI tools you're talking about require strong infrastructure, updated systems, and fully staffed teams who can't actually respond to alerts or interpret new data. That describes well-funded hospitals, not safety net hospitals or rural clinics. When the same technology is put under resource settings, it causes alert fatigue, system errors, delays, and confusion. So while your evidence is correct, the scope is limited. Technology improves outcomes only in environments built to support it, which means that improvements go to the already advantaged groups. Both of your arguments actually reinforce mine. Technology amplifies whatever system it enters. So if a hospital has resources, the tech raises its quality. If a hospital lacks resources, tech widens disparities. So my final point is kind of this, responding to both you guys and Joe too. Technology is not neutral. It gravitates towards power. It benefits people with strong insurance, digital literacy, and access to modern medical systems while leaving everyone else behind. Professor Marmot in 2005, who kind of studied how social determinants of health inequalities affect society, kind of brought me to this opinion almost that through a conflict theory lens, technology isn't the great equalizer. It's another mechanism that preserves existing hierarchies in healthcare. And technology has the potential to transform care, but under our current system, it's just unequal, and it does it unequally. If we don't address the structural inequalities first, then every new innovation will just deepen the divide that we already have. And those are my final points. Thank you.
It's important to note that when technology is implemented responsibly and supported by proper infrastructure, it consistently improves health outcomes for most populations. We can understand this through stratification theory. Inequality persists. Wealthier patients often get access first, but the theory also shows that upward movement can happen across all classes. In healthcare, this means that outcomes can improve for every group at the same time. Wealthier patients may gain faster, but underserved populations also see major benefits when technology enables early detection, better chronic disease management, and access to specialists they never had before. For instance, remote cardiac monitoring has been shown to reduce mortality by 15 to 20%, alerting clinicians to irregular heart rhythms before they become life-threatening. According to a 2023 systematic review published in JMIRM Health and UHealth, patients using remote monitoring were able to receive interventions earlier, which translates into thousands of lives saved. Digital prenatal care programs provide another example. Research published in BMC Health Services Research found that low-income patients using telehealth prenatal platforms experienced improved maternal and neonatal outcomes, including fewer complications and healthier pregnancies. These programs offered continuous communication, appointment reminders, nutrition tracking, and virtual check-ins, reducing the impact of transportation barriers and inconsistent care. Similarly, a 2024 study in JMIR M Health and U Health found that remote blood pressure monitoring for high-risk pregnant individuals increased adherence to monitoring protocols, leading to early detection of complications. This shows that technology doesn't just convenience patients, it directly improves outcomes. These tools don't replace human providers, they extend their reach and allow clinicians to intervene earlier. That frees providers to focus on complex cases, improves patient follow-up, and strengthens continuity of care. So when responding to earlier speakers, Rithika is right that technology isn't perfect, but research shows it saves lives and improves outcomes. Jacob is correct that access gaps exist, but even underserved populations benefit significantly. And for those who worry about equity, the answer is thoughtful implementation and infrastructure, not rejecting effective tools. In short, technology improves outcomes for the majority of patients, from cardiac monitoring to digital prenatal care to better chronic disease management and specialist access. Tech pushes health systems towards faster, safer, and more consistent care. Inequality is real, but progress is real too, and technology is driving much of that progress as research clearly demonstrates.
So now we arrive at the end and we arrive at the big question. Does technology narrow or widen inequality at the end of the day? Rithika says that it widens inequality. Jacob says it improves outcomes but widens the gap. And Annabelle says it helps most people but doesn't erase inequality. My view, different from the other three, is that healthcare technology is actually our best shot at shrinking inequality over time. Not immediately, not short run, but absolutely in the long run. Think about telehealth and remote care. The WHO, or the World Health Organization, has shown that telehealth improves outcomes in rural and underserved or impoverished population because it gives them this newfound access that they didn't have before. This is an objective fact, as access is the root of everything. Outcomes, prevention, survival rates, quality of life. This all starts at access. The richest people are considered so powerful and rich, not just because of their money, but because of their networking, their connections, and their access. Now, speaking of the rich, does tech benefit wealthy patients first? Usually, yes. Does it mean it's going to stay that way? Not necessarily. That's not necessarily how innovation works. While the rich are always going to have an edge, vaccines or antibiotics, and now what we're seeing with new technology, genome testing, all follow the same path. Expensive, then adopted by the rich or wealthy systems, then standardized, then affordable, and then eventually universal. Some of the things that we're seeing nowadays, like the flu shot, at first, I'm going to assume was a privilege that was only seen by the rich. But now we see that pretty much everyone is able to just get a flu shot at a local CVS. Now, I'm not saying every single person, as there are people that aren't even able to get to a CVS, but that's more just used as an example of how things can be a luxury and then turned into something that's just universal. Annabelle says that inequality may still linger, and she's right. I'm not here to argue that we're going to enter a communist society where everyone is the same. But lingering inequality doesn't mean tech has failed. It means that we have to decide whether we want to scale these tools in a way that closes the gap rather than stabilizing the gap. So here's my closing piece, my closing argument, as I have voiced all of my arguments throughout these 15 minutes. If we freeze healthcare technology exactly where it is today, then yes, inequality would deepen. You have heard me say short-run inequality right now is present. But if we keep innovating, regulating, even expanding tech into safety net systems, something I read up on, then technology becomes what I call the engine of equity, not the enemy of it. We can't fix inequality by stepping backward, but in my opinion, if we continue to push forward through the short-term inequality, then we will push forward smarter, faster, and with everyone included, closing the gap of inequality. Thank you.